Okay, so we're back now to talk about this last section of this roundtable, and it's really around the current trials and maybe some of the additional agents that are being studied around PSMA and directed therapies. And I want to start, Raina, with you in the PSMA 4 trial.
Mhm.
Can you walk us through kind of the basic schema of this study and you know where that is? What do you think of this study?
Absolutely. So, this study is basically being designed in the pre-chemotherapy CRPC setting for patients with prostate cancer. So, Vision was really in the treatment refractory setting. We demonstrated that we could make people live longer. Well, actually, if we move therapy earlier on in the CRPC course prior to receipt of chemotherapy, docetaxel, taxane chemotherapy, can we still see the same benefit? And so essentially the trial is, looking at, I believe it's a combination with abiraterone, that I could be wrong. Oliver, I'm going to kind of volley it over to you.
It's very similar to the Profound study.
Got randomized to the sister drug and then single
Yeah,
agent
you get the
lutetium.
physician's choice and the control arm. It was interesting. It was proposed initially as a standard of care plus or minus, and even though the FDA sort of accepted the standard of care plus or minus in the Vision, they did not accept it here. So it's an alternative AR pathway inhibitor versus the lutetium.
And then I think thinking about PSMA addition, which is now looking at things in the hormone sensitive setting. And I think in that context, that study is designed where patients are not to receive chemotherapy. So it's really designed at looking at the combination of an AR targeting agent with or without lutetium in that context. And then, I know we've got Preston here on the phone or on the call on our video. You got to bring it back to the infamous lutectomy of looking at PSMA in the neoadjuvant setting. I'm sure you can comment on that.
Yeah. Let's go. Preston, let's go to you because I think that particularly that PSMA addition study is going to give us some insights into sort of the local treatment effects of this agent, and I'd be curious, from your perspective on, from a urology perspective, how you view that.
I am intrigued by it. I think, there are many side effects to treating localized prostate cancer. And so I think, and we are seeing that lutetium is very effective in men with this high risk disease. We can only hope that it's going to be even more effective when you don't have all those mutations and different, selected sort of bad actor types of cancer in later metastatic resistant prostate cancer. So potentially treating earlier will have even more effect. Seems to be pretty well tolerated. It's obviously different side effects than urinary incontinence and erectile dysfunction, which is what we see with surgical prostatectomy. But I think, quite honestly, we're going to be trying to find a balance. If we can do lutetium-based diagnosis and treatment with local therapy control of the prostate, it may not be perfect, but if it can be effective enough to give people additional time away from surgery, away from some of the other significant quality of life deficits that we cause with local treatment, I'm very excited to see how it plays out.
Excellent. Yeah, I think there's a lot of uncharted waters here, and really opportunities to learn from multiple trials here, where this fits in these, as you can see, kind of earlier stages of the continuum of this disease. And it's not the only agent, right, Oliver? There's another phase 3 going on with another PSMA targeted strategy. Want to walk us through that?
Yeah, there is. There's we've been talking about PSMA 617, lutetium 177, and that's the one that's got most of the press because of the Vision trial and all. But there's another one that's proceeding right now, and that one is called PSMA INT, lutetium 177. It's a different moiety for binding to the PSMA. It's still a small molecule, and the PSMA INT is very similarly being studied as the PSMA 4. They call their trial the SPLASH trial. And the SPLASH trial is going to be looking at kind of an alternative AR targeting agent, metastatic CRPC in the pre-chemo setting, if you will. Also an RPFS endpoint. So, yeah, we got, and there's another one coming, by the way. There's another PSMA INT lutetium 177 that's been announced, and we're just gonna have to wait to see. It's not up and running yet, but there are lots of ways to be able to attack PSMA, and then of course ways in which novel isotopes are being used as well. And I just mentioned things like actinium-225. And we don't have enough time to really talk about all the different isotopes and all the different moieties that are binding, but this is a very active investigational area. It's not just PSMA 617, lutetium 177, but that's in the lead. That molecule's in the lead.
That is fantastic, Oliver. Thank you. And I think this really, I think, really frames the fact that this is likely to be a whole paradigm shift in the way we think about the treatment modalities for prostate cancer. When you think about where we've gone from strontium and samarium to radium, really targeting bone with alpha particles, but really limited to bone, and now moving on to really more direct tumor targeted approaches with PSMA, and thinking about that, changing those warheads and changing those small molecules. It really does sound like there'll be potentially a portfolio of choices to build off of. And as Raina mentioned, as Preston mentioned, the clinical context in which we'll study these drugs in earlier disease states and in earlier settings, that if we've learned anything from prostate cancer in the last couple of years, including at GU ASCO, it's timing matters, and timing with hormonal therapy, timing with AR targeted agents. And some of that timing will be studied now in some of these earlier disease settings. Well, I can't thank you all enough for this really interesting, I think, inspiring discussion around lutetium 177 PSMA and the potential rollout of this in the near future, and what implications we have for this year and things to look forward to in the years to come. Thank you all for joining, and on behalf of my roundtable colleagues, thank you all for listening today.